Hello and welcome to this introductory video on the use of ultrasound in reproductive health. My name is Alan Shim and I am the Director of Ultrasound Education at DGUSOM. I hope this video will complement your learning in Foundations of Practice and Scientific Foundations of Medicine and help to strengthen your understanding between the anatomy and the physical exam. I also hope that the clinical cases in this video will give you context and purpose to what you're studying. So, let's get started. In this video, we will discuss the advantages and disadvantages of ultrasound, the normal anatomy and the basic technique of ultrasound, and its use in the evaluation of these common clinical presentations. So, why is ultrasound usually first-line imaging in reproductive health problems? First, the spatial resolution actually exceeds that of radiography and usually CT, and it can often be comparable to MRI imaging. Second, you can capture vascular flow by using color and quantitative Doppler modes, which is important in both diagnosing lack of flow, as in testicular or ovarian torsion, as well as increased flow that you might see in infection and inflammation, the itises. Flow in abnormal structures such as cysts may also imply vascularity and an increased likelihood that the cyst is malignant. Last, and this is very important to patient care, is that ultrasound is associated with the least amount of potential harm to the patients. When it comes to imaging, there's a very important principle called ALARA. This stands for as low as reasonably achievable. In terms of imaging studies, we try to give just enough radiation to be able to achieve our imaging goals. So in the case of a lot of reproductive health problems, we try to avoid this excess radiation because we're talking about a very sensitive area where there's a lot of genetic material. And we know that the more ionizing radiation that you have to that area, the more likely you're going to lead to an increased risk of malignancy as well as genetic damage. Ultrasound avoids this issue because there is really no ionizing radiation. Now, there are other things that are associated with heating of tissue with ultrasound waves, but that is much less of a risk than with ionizing radiation from either plain films or CT scans. Now, there are other considerations. The time it takes to order and perform a radiology ultrasound or CT or MRI, and this can mean an additional few hours in the outpatient setting or even a day or two if the patient is admitted. And not to mention there's also the added costs. So what are the limitations in terms of using ultrasound? Honestly, the main limitation is you, and that's what we call operator dependent. You see, most ultrasounds are performed by ultrasound technologists, and they do a great job in obtaining these studies, but they don't go to medical school and so lack that medical knowledge. And the radiologists who interpret the images, they do go to school, obviously, but they don't see or examine the patients, so they lack that clinical perspective that you get from the history and physical. Now, as physicians in training at DGUSM, we believe that it is crucial that you become familiar and confident with ultrasound so that you could spend more time with your patients at the bedside and arrive at the diagnosis quicker and more confidently with your POCUS skills. And by the way, if you are interested in more features of this DGUSM POCUS curriculum, please check out our website here using the QR code. Now, the other limitations have to do with imaging approaches. With transabdominal, you are imaging through several centimeters of abdominal wall before reaching the peritoneum, and then you have bowel gas that will scatter your sound waves. Notice that your depth is often below 10 centimeters, so you really need a low-frequency probe to reduce attenuation of the sound waves. Also notice that you need a full bladder as an acoustic window. Without a bladder, the sound waves will encounter air from the adjacent bowel here, and you won't be able to reach the structures of interest. Now contrast this to transvaginal ultrasound here. The probe is inserted into the vagina and is next to the cervix. The image quality is much better because number one, the probe is next to the uterus or adnexa, and number two, we are using a high-frequency intracavitary probe. Notice also that you want an empty bladder for transvaginal ultrasound because a full bladder will push the uterus more superiorly and away from the probe. In fact, the technique for transvaginal ultrasound is similar to the bimanual exam, in which you place a hand near the umbilicus or the belly button, and you're like pushing downward onto the fundus of the uterus. And what you're trying to do is you're trying to move that uterus closer to allow for palpation with your other hand. In the case of transvaginal ultrasound, you're trying to move those structures close to the probe so you get better resolution. Now for scrotal ultrasound, you use a high-frequency linear probe, and that's just placed adjacent to the structures, and you get very good resolution as well. Now let's start with normal anatomy on ultrasound. Let's first take a look at male anatomy from a transabdominal approach. Here the two vas deferens each meet with an adjacent seminal vesicle, posterior inferior to the bladder, before entering the prostate and becoming part of the urethra. On a transverse view at the level of the bladder, you can identify the two seminal vesicles here and here. Here are the vas deferens, but often they are too small to visualize on ultrasound. As you tilt more inferiorly, you will see the prostate, this small structure here. Note that the pubic symphysis inferiorly and bile gas superiorly limit your ability to completely visualize the prostate, and that you really need a full bladder as an acoustic window. A 67-year-old male comes in with polyuria and increased suprapubic pressure for the past several weeks. He attempts to urinate every hour, but he really can't fully void, and he doesn't really have any GU or infectious symptoms, and his POCUS is below. What's your diagnosis? Yes, that is an enlarged bladder, and that's leading to urinary retention. Congratulations, you made the diagnosis. This is confirmed with an elevated post-void residual, or PVR, which is normally less than 150 to 200 cc's. A Foley catheter is placed, relieving his bladder outlet obstruction and his symptoms, and in consultation with urology, he's prescribed tamsulosin, and his workup, including blood tests and other imaging, is initiated. Now let's move on to the scrotal and testicular structures. For the first ultrasound window, the patient is laying supine, and a towel is placed underneath the scrotum to elevate it. A linear or curvilinear probe is placed in the coronal plane, indicator that pointed to the patient's right, and the scan plane is pointed superiorly, as you see here. This is called the sunglasses view or the buddy shot because, the testicles are buddies and they're hanging out together. All joking aside, many testicular findings are unilateral, so this view allows you to compare the affected side with the unaffected side. You can often see the external dartus muscle separated from the inner cremasteric muscle by the external fascia here, which is often very echogenic. The two layers of the tunica vaginalis are here and can only be seen when there is a hydrocele or fluid between the two layers. The median raphe separates both testicles, but usually you can't see the entire septation due to the combination of anisotropy and attenuation on ultrasound. Remember that the probe always sits at the top of the screen here, so because it is pointed inferior to superior, the top of the screen is inferior here, and the bottom of the screen is more superior. This is why the neurovascular structures are shown below here. Lastly, the testicles should look smooth and homogeneous in appearance. It usually has the same echogenicity as the liver or spleen, for example. Here is a long axis of the testicle, which can be obtained by moving the probe to the side while still in a coronal plane. Because the probe is now pointed lateral to medial, the top of the screen now is lateral while the deeper structures are medial. Note that there is a small hydrocele again between the parietal and visceral layers of the tunica vaginalis. Also note this hyperechoic border around the testicle, which is, yep, you guessed it, the tunica albuginea. Now moving posteriorly, you can image the tunica albuginea merging together to form the fibrous mediastinum testes, which is seen as a hyperechoic line here running superior to inferior. To obtain a short axis of the testicle, you just need to rotate the indicator dot anteriorly so that you get a cross-section of the testes here, and then you can kind of slide up and down. The higher up you go, the more of the epididymis you'll see right here, which looks like kind of a half circle just behind the testes. The epididymis is an important structure. It has a head, a body, and a tail, and it contains the tubules that eventually become the vas deferens. Now, it sits on top of the testicle, and behind it And it kind of reminds me of a hairstyle. Yeah, that's it. It's short on top and long in the back. That's right, it's the mullet to the testicular head. You'll never forget where the epididymis is now. There are a couple of different planes to image the epididymis. The first is just from a coronal view where the probe is situated lateral to medial, and you can see the epididymal head on top here. The second is a side profile where you're actually imaging a sagittal view of the testicle. So this is anterior and this is posterior, and behind is the long body and tail of the epididymis. And this is a short axis of both testicle and epididymis, where you can scroll from a superior to inferior plane. The vascular structures of the testicle travel in the spermatic cord, and they essentially follow the same path as the epididymis. There's a rich supply. You have arteries from the testicular artery as well as from the vas deferens, and you'll notice that there's a capsular artery with centripetal vessels or arteries in the testicle itself. And on the venous side, there's a rich collection of veins that make up the pampiniform plexus, one of my favorite words in medicine. I feel like I have to drink tea to say that. And here's an ultrasound showing both capsular vessels as well as the centripetal vessels, including arteries and veins that are in the testicle. Let's talk about some clinical cases. The type of presentation is very, very important when it comes to a chief complaint involving the testicle. So if someone comes in with abrupt, sharp, debilitating pain like this gentleman right here, and it can also be intermittent, but the key is that it really, really is very, very sharp. You really have to consider testicular torsion. And testicular torsion is torsion around the spermatic cord so that you have ischemia to the testicle itself. Oftentimes is associated with something called a bell clapper deformity, where the tunica vaginalis attaches higher than usual and not around the testicle itself. And because of this, there's an increased likelihood of twisting around the spermatic cord and leading to torsion. And really important to mention is torsion is a clinical diagnosis. So while ultrasound can help to rule it in, you cannot use it to rule it out. And it's such an emergency diagnosis that if you go after 24 hours from the onset of torsion, the testicle is gone. 6 hours or below is ideal for optimal salvage of the testicle. So here's an example of a testicle with no flow on color Doppler. And this is a testicle that essentially is an old testicle where you already see evidence of edema as well as some debris in the testicle itself. Now let's go to acute pain in the testicle, but it's more constant and it's not particularly sharp, but definitely very, very painful. And oftentimes there are infectious symptoms like fever, maybe there's dysuria, there's maybe penile discharge. And in that case, you really have to consider an infection of either the testicle, what we call orchitis, inflammation or infection of the epididymis or epididymitis. And if it continues to ascend, you can actually have an infection of the prostate or prostatitis. And this is that sunglasses view or the buddy shot where you can see increased flow to the right testicle compared to less flow to the left one. And if the patient has right-sided pain right here, then this is really good evidence that this is orchitis. This is epididymitis, and essentially it's on the continuum with orchitis, so that it's called epididoorchitis. But you can appreciate in this short axis window increased flow around the epididymal head, and then this is that long axis view where you can see increased flow in the body of the epididymis. Now, if you have kind of less painful, but still with some pain, and that pain is worth withstanding or lifting, what can be pretty common is an inguinal hernia that is in the scrotal sac, and if you use ultrasound, you'll see these loops of bowel that are actually kind of moving, and this is peristalsis. The other consideration is when you have a dilatation of the pampiniform plexus, and that could be due to systemic factors. It could be the valves in the veins being incompetent. And what you'll feel is that kind of the classic worm-like presentation or worm-like sensation. And what you would see on ultrasound are these dilated structures here. And if you put color Doppler on, you'll see that these are vascular structures, and that gives you the diagnosis of a varicocele. And most varicocele on the left side. Remember what you learned before about nutcracker syndrome, that the testicular vein drains into the left renal vein on the left side. And if you have an SMA syndrome, that is going to lead to decreased venous return and then engorgement of the testicular vein, leading to engorgement of the pampiniform plexus and a varicocele. And it's very, very uncommon to have a right-sided varicocele. In fact, if you had a right-sided varicocele, there should be a workup for some sort of impingement of the IVC itself. Now, the last type of presentation is kind of like dull or no pain with testicular mass or swelling. And this is really the most ominous, because that can tell us that potentially that there might be a malignancy. You guys had your FOP session where you palpated simulated testicles, and this is what they would look like on ultrasound. So if you had like an abnormal mass, you put some color on, there's flow in the testicle in this mass itself, then that is really, really concerned for vascularity and a malignancy. Other things are if you just have like a change in density. This is a seminoma right here, and it's much less dense than the testicle around it. If you had calcifications, this is actually called microlithiasis, and this is pretty prominent. And you can see that it's really dense, so it's very hyperechoic. So any of these things should really tip you off that potentially there is malignancy, and these patients really need early follow-up. Okay, now let's take a quick break before we go into female anatomy. All right, let's talk about the uterus and long axis. Remember that the uterus is just posterior to the bladder and superior as well. So it kind of cups the bladder. And this is a little bit more apparent when you rotate, and you could see it from the side like here, where the bladder kind of sits right here and the uterus is posterior and superior to the bladder. In terms of the ultrasound, you want to use a curvilinear probe with the indicator dot pointed towards the head. And this is what you would get right here. So the probe would sit somewhere here, and it would shoot through the bladder, and you get this long axis view of the uterus from the fundus, the body, to about where the cervix is. And as you fan or tilt your probe side to side, you'll start to go from uterus to ovary here. And you'll also be able to appreciate the iliac artery and vein here, as well as you tilt side to side. In terms of the uterus long axis, remember that your probe is now in the vagina, and it's right next to the cervix and the proximal uterus. And the indicator dot should point anteriorly, and your scan plane is actually shooting from inferior to superior. And this is why on the ultrasound image, this is anterior, because your indicator dot is aligned with the dot on the probe. So this is anterior, and this is posterior. This is the rectum here, the sigmoid colon. And what you'll notice is that this is also inferior, and it points more superiorly. So the fundus is anterior, the cervix and the rectum are more posterior, and the cervix compared to the fundus is more inferior, and the fundus is more superior. In terms of the ultrasound image, you'll want to kind of fan back and forth side by side just like this, and what you'll see is the uterus here with the endometrial stripe. And as you fan side to side, you'll start to see the ovaries. Here's the right ovary. And then as you tilt or fan to the left, you'll see the left ovary. And remember that the handle is opposite the scan plane. In terms of the short axis, what you want to have on a transabdominal approach is to have the probe rotated in this fashion, where the indicator dot points to the patient's right or your left. And what you just want to do is you want to kind of fan or slide the probe more superiorly or inferiorly. And when you do that, you're kind of like imaging more of the fundus as you tilt a little bit more superiorly. And as you tilt more inferiorly, you go towards the cervix. And this is what it will look like when you're fanning the probe superiorly. You see the fundus of the uterus, the bladder, and the cervix below that. And there are a couple of surprises as you tilt more. So one is this IUD, which is very, very echogenic. And there is a pregnancy, actually, an intrauterine pregnancy right there. So the short axis of the uterus on a transvaginal approach is really, really challenging. And just remember, though, that the uterus will kind of curve upwards so that the fundus is anterior and superior compared to the cervix, which is more posterior and inferior. And so if you insert the transvaginal probe, it's going to sit right here, and this will be your scan plane. As you tilt more anteriorly, you get more of the body and the fundus of the uterus, as well as the ovaries. In terms of orientation, the indicator dot points to the patient's right or your left, and this coincides with the same indicator dot on the screen. So whatever you're looking to your left or the patient's right will also be on the left or the patient's right on the screen. Sorry, I had a little shooting fail. So you're tilting anteriorly, you see the uterus, and then you see the ovaries. This is the right ovary and the left ovary, and if you just kind of rock the probe like this, you'll kind of be able to visualize the ovaries a little bit better. And remember that you're using your opposite hand to push down on the umbilicus so that you're moving the uterus closer to your window. All right, let's do a case. You have a 55-year-old woman who is postmenopausal, and she comes in with vaginal bleeding for 3 days. This is her pelvic ultrasound right here. So this is a transvaginal sagittal view of her uterus, and here, somewhere here is the serosal layer. Here's the myometrium, and then this is the endometrial complex or stripe of her uterus. It looks abnormally thickened, and one question is, how do you quantify that thickness? You want to measure the transverse diameter from the basalis layer to the other basalis layer, and in most machines you can actually change the tone of the images so that you get a little bit better contrast between the myometrium and the endometrium here. So this is 8 millimeters, and this is really abnormal. So what do you do next? If you chose ask your gynecologist to perform an endometrial biopsy, that is correct, because this is a clearly abnormal endometrial thickness for a postmenopausal woman. In fact, most postmenopausal women really should have an endometrial thickness less than 4 millimeters. And if it's greater than 4 millimeters, then really you need to do an endometrial biopsy and proceed from there. So let's talk about uterine changes during the menstrual cycle. You guys are well acquainted with this very popular figure right here. And I remember it so well that it's kind of seared into my mind. And it's very, very convoluted with all these loops of hormonal levels over time. So one way to simplify this is to focus on the ovarian cycle and the uterine cycle. And at this point, let's just focus on the uterine cycle. And what you'll notice is that there are 3 distinct phases. There's menstruation, where you have sloughing off of the functional layer. Then you actually have proliferation around day 7 after the first day of menses, where the endometrium is starting to be stimulated by estrogen, and it starts to thicken in preparation for ovulation, which is about mid-cycle. And then after that, you actually have the secretory phase, which is production of nutrient-rich glycogens in the endometrium in preparation for a pregnancy. And that's primarily driven by progesterone. So a way to look at this is to think about a sponge. This green part of the sponge is the basalis layer, and it's permanent, doesn't move, doesn't change at all. Now, if it is thin like this is right after menstruation, and you have a really thin stripe. As you get proliferation of the endometrium by estrogen, you get this thickening right here, and you'll see this 3-layer. This is called a trilaminar sandwich. I didn't make that up. The thickness is about 10 millimeters, 6 to 10 millimeters. And after ovulation, you have the secretory phase. So you'll start to see this functional layer, which is normally hypoechoic, becomes more hyperechoic due to secretion of those glands. And when it becomes virtually homogeneous and echogenic like here, then that tells you that you're very much at the end part of the secretory phase and ready for the first part of menstruation. Now, where do these hormones come from? Well, they come from your ovaries, and these are really key slides. This tells you this is the thecal cells and the granulosa cells. There's a basement membrane pre-ovulation, and what you'll notice is that you can make androgens, they diffuse through, and the aromatase makes the estrogen, which is predominant pre-ovulation. Now, after ovulation, you actually have breaking down that basement membrane, and then progesterone as well as LH is able to bind to these LH receptors here to make more progesterone. And basically, you have an increase of progesterone, which promotes the secretory phase. Let's talk about case 2. This is a 32-year-old woman with heavy menstrual bleeding. And importantly, you want to ask if there's any signs of anemia or symptoms of anemia because of her menstrual bleeding. Things like dyspnea, feeling tiredness, having chest pain, etc. Fortunately, her hemoglobin is not too bad. It's at 10.4. And this is her pelvic ultrasound right here. This is a transabdominal sagittal window. And you see something right here just in the posterior myometrium. So on transvaginal ultrasound, you get this same mass right here that is primarily in the myometrium. And if you guess that this is a fibroid, you are correct. Now, what is the next step in terms of her treatment plan? If you guys said that it depends on her reproductive history and her plans, that is correct. So this mnemonic, POM COEIN, is a very, very helpful mnemonic for the causes of vaginal bleeding, from structural to non-structural, POM being structural, and essentially all things that you could diagnose on ultrasound. Whereas COEIN has things like coagulopathy, ovarian dysfunction, iatrogenic causes, and those often depend on both ultrasound and some serologies like hormonal levels. Fibroids are very, very common, and they have a major impact in terms of fertility and as well as pregnancy complications. This is the FIGO classification of uterine fibroids. You probably have seen this classification, but it depends on the location of the fibroid for whether it's kind of intraluminal, submucosal, in the myometrium or in the serosa. And the treatment options are bound depending on their fertility wishes, short-term, long-term, as well as whether they've tried medical approaches. Then you might have surgical approaches here. So let's talk about case 3. This is a 21-year-old woman who comes in with irregular menses for the past 3 months or so, and she's also developed left-sided pelvic pain. She is not pregnant with a negative beta HCG, and this is an ultrasound of her left adnexa. So you'll see that this is a cystic structure. There's no echogenicity in the cyst itself. There's a little bit of posterior acoustic enhancement, meaning that there is nothing solid to attenuate the sound waves as it goes past, and that as a result, the structures deeper look brighter than superficial to the cyst right here. So what is your best choice? So simple physiologic cysts are usually 3 centimeters or less, and this is greater than that. So this is a simple ovarian cyst. A complex cyst, there's some criteria for when it becomes complex, when they're like internal echoes or structures inside the cyst, like these septations, if there's something, projections in the wall of the cyst, if there is any vascularity, for instance, as well, that makes it complex. Not all simple appearing cysts have low risk for malignancy. Here are some characteristics that point towards low risk versus high risk. So let's talk about the ovarian changes in the menstrual cycle. Just as we talked about the uterine changes with the functional layer, we have the ovarian changes, and you can break that down to just 2 phases, the follicular phase and the luteal phase. And with the follicular phase, that is driven basically by estrogen from FSH, and you go from multiple follicles to selection of a primary follicle, and that follicle will develop until you have ovulation, and that follicle becomes the corpus luteum, which signifies the luteal phase. And remember that the corpus luteum actually secretes progesterone during this luteal phase, and that helps to stabilize that endometrium for implantation for pregnancy. So on ultrasound, this is what you would see. You would see these follicles with really no dominant or primary follicle. And as you progress to the first week of after your menstrual cycle, you start to select a dominant follicle, which is roughly 3 centimeters or less. And as you approach ovulation, you'll start to see this grafting follicle right here. And after ovulation, this will rupture with the egg release. And here is the corpus luteal cyst during the luteal phase. And as it starts to regress, you'll start to see the corpus albicans, which becomes a little bit more hyperechoic, and it starts to essentially fade away. Sometimes you'll get rupture of some blood into the corpus luteal cyst, and that becomes a hemorrhagic ovarian cyst. How do you find the ovaries on transabdominal ultrasound? So you start at the bladder, and as you tilt more superiorly, you'll start to see the fundus of the uterus, and the ovaries are medial to the iliac vessel. So on ultrasound, you'll want to identify the iliac vessels here. You'll want to confirm that with color Doppler, and when you see that, you just want to fan a little bit more anteriorly or superiorly, and you'll see the vessels dive down here. As you dive down, you'll start to see the ovary just medial to the vessels. Here's another tip on how to find the ovaries on transabdominal ultrasound, and this is to identify the fundus here, and the fundus has these little horns, the cornu, and if you just kind of find the horns like here, you'll be able to kind of rock the probe laterally and you'll find the ovary as well. As we discussed, one major limitation to transabdominal ultrasound is that it doesn't give you that detail because you're far away from structures. So often for adnexal or ovarian visualization, you really need to use transvaginal ultrasound. So this is case 4. So she's a 26-year-old woman who comes in with left lower quadrant pain that is pretty severe at onset, and it's been intermittent. She's not pregnant, and her pelvic exam shows no evidence of infection with no vaginal discharge or cervical motion tenderness. And this is what you see on her ultrasound, this cystic structure. If you were to characterize it, you could say that there are definitely some internal structures. They look like different densities. In fact, this one is shadowing. These are not really shadowing, and then there's some fluid in there too. So definitely concerning for a complex cyst. So what do you think it is? Definitely not a simple cyst, as we discussed. Should be removed as it increases the risk of ovarian torsion. Remember that presentation and how similar it is to testicular torsion. So that should raise your suspicion. And C, is it a germ cell tumor? If you chose D, you got it correctly, because this is what a cystic teratoma or dermoid cyst is. It's actually different cell types. You have like kind of like the fat right here in keratin. You have some bone components that cause shadowing, and then you have some fluid or components as well. And this is highly associated with torsion. It actually increases your risk of ovarian torsion by 8 to 10. And this is why when you have a dermoid cyst or a cystic teratoma, often the treatment is to actually remove that. So this is it's kind of like a gross path of that. You could see that there are hair follicles. There's no more fluid in there, but there's hair. There's a little bit of almost like a tooth here as well. So on ultrasound, you can look for like these floating balls, but really it's just if you see like mixed components that should tell you that potentially this is a dermoid cyst. So ovarian torsion, we have dual supply to the ovaries with the ovarian artery, as well as the communication from the uterus itself, this communicating artery. Similar to your evaluation of the testicle, you're going to put some color on the ovary, and here there's no flow. And the ovaries themselves should be homogeneous as well, except for these follicles. So here you could see that it's not homogeneous. There's relatively hypoechoic and hyperechoic elements to this ovary, and this should really raise your suspicion for ovarian torsion. And just like testicular torsion, ovarian torsion is a clinical diagnosis. So if you see these signs, that definitely will rule in torsion. But if you see flow, remember that you can have basically intermittent torsion, where you can have resumption of flow, but that patient's ovary is still at risk. And so you really need to think about surgery at that point. These are ovarian cysts of different types. These are very common ovarian cysts that have very low malignancy potential. The first one is an hemorrhagic ovarian cyst, and this is essentially an ovarian cyst that increases in size, and it will rupture into some adjacent blood vessels, and you get these like fibrin strands right here that are in what's called like a fishnet or lace-like appearance, and that can change over time as the clot starts to retract. It might just be kind of a mass right here, and those typically will resolve after about a couple of months. But sometimes these will rupture, and they may actually lead to some hemoperitoneum or blood in the peritoneum. Now, this is an endometrioma. This is associated with endometriosis, and this is an ectopic endometrial tissue from the uterus that migrates its way up to the ovary, and it implants, and it becomes a cyst. And the characteristic feature is this ground glass appearance. I don't know. Ground glass is thrown around a lot in medicine. But basically, it's just like this kind of homogeneous echo that you'll see. And endometriosis is a very common cause of chronic pelvic pain. And oftentimes, if you see an endometrioma and the patient has months-long, maybe years-long pelvic pain, that is probably the diagnosis. Now, this cystic teratoma, again, you see different composition materials in the cyst itself, some with shadowing, some that are more lipid in nature, and then some that are kind of like more serous in nature. And at this stage of your training, you don't really have to memorize what these different cysts look like, but this is just an introduction on very, very common ovarian cysts. So thank you for watching my video. If you have any questions or if you want to schedule a scan shift, this is my email on MedNet. You guys have a lot of material ahead of you, but, listen to Dory and just keep swimming. No, I'm not going to try to sing. So these are videos that are really helpful. This is a really great video on scrotal ultrasound. This is one on the endometrium. Dan Weingrow, my colleague, gives a really great pelvic ultrasound from the EM perspective, as well as Dr. Elena Plume, also from UCLA. She gives a great video as well. These are some resources that I've used for my talk. Everything from Visible Body, which gives you like a 3D approach. POCUS 101 has great medical student resources. Radiopedia, you guys have heard of that. And then the International Federation of Gynecology and Obstetrics, they have really, really great resources, documents on a lot of women's health research and guidelines. Thanks again for watching, and just keep scanning, just keep scanning.